Welcome to Breaking Down Nursing. Nursing is challenging enough, but you don't have to do it alone. Breaking Down Nursing is here to guide you through exams, clinical prep, and everything in between. Today we're going to focus on NCLEX priority questions. Do you ever freeze when you see those tricky NCLEX priority questions? Don't worry. By the end of this video, you're going to know exactly how to use the ABCs, airway, breathing, and circulation, to choose the best answer for your priority questions. Why do the ABCs matter? Well, the NCLEX loves to test your ability to prioritize. And the ABC framework, airway, breathing, and circulation, is your best tool. Think of it as a survival hierarchy. Without an airway, nothing matters. Without breathing, circulation can't happen. And without circulation, oxygen can't reach the tissues. The order matters because the body can survive only minutes without oxygen. That's why NCLEX questions expect you to prioritize airway first, then breathing, then circulation. It mirrors exactly how we deliver care in emergencies and clinical practice. So let's go through each of these step by step. We'll start with the first step, airway. When we think of airway, we want to think of, is it patent or not? Is the air from outside in the atmosphere able to get to the lungs? If the airway is blocked or threatened, that's the highest priority. Some of the common causes you'll see in the NCLEX or in common practice are things like choking, foreign body or food lodged into the throat, swelling caused by anaphylaxis or allergic reaction, trauma, severe facial burns. Swelling can cause obstruction in the upper or lower airway very quickly. So if you see those singed oral mucosa or singed nares, we have high level suspicion that that same swelling is happening lower as well. And last but not least, snoring or gurgling. These are signs that the airway is partially obstructed, but the progression to full obstruction could happen fast. When you hear or read these cues in the question, that's your signal. This is an airway problem, and it takes priority over breathing and circulation. When we think of breathing, we just think of generally the ability to move air in and out. But really, breathing's broken down into two subcategories, our ability for oxygenation and ventilation. So let's talk about each of these. So we'll start with oxygenation. Oxygenation really is the ability's body to move oxygen from the lungs into the bloodstream so it can reach our vital organs and our tissues. Even if the airway is clear, oxygenation can still fail if the lungs aren't exchanging gas effectively, or if our oxygen on our hemoglobin is not getting all the way to the tissues. Oxygen is the final electron acceptor in cellular respiration. Remember, we're aerobic creatures. Without oxygen, the body can't officially make ATP. The energy cells need to function. Instead, cells switch to anaerobic metabolism, which produce far less energy and creates a lactic acid as a byproduct. That's why patients with poor oxygenation may develop lactic acidosis and show signs of organ failure if it's not corrected. This is also why we use lactic acid as a marker of sepsis. We measure oxygenation in several ways. Some examples would be pulse oximetry, which is a reading to see how well oxygen is saturating in our bloodstream. So that's why we have that little alligator clamp that we put on fingers. The other way to know is cyanosis, or that bluish tinged color that our patients get, which tells us that we have impaired oxygen delivery. If oxygenation is inadequate, some of the ways we may be able to fix it would be by providing supplemental oxygen. Start with a nasal cannula for mild needs. Use a non-rebreather for acute or severe hypoxia. For any critical cases, we can increase our oxygen needs to high flow, putting them on mask as necessary. The key for oxygenation is quickly identifying it. Now let's talk about ventilation, the step that often gets overlooked when we focus on oxygen. Ventilation is our ability to move CO2 out of our body. Well, why is this important? Well, CO2 acts as an acid in our body, that our pH changes based off of our acid-base balance. Just remember, pH and CO2 have an inverse relationship. So ventilation controls acid-base. For example, in DKA, the body can't use glucose, so it breaks down fat. This produces ketones causing metabolic acidosis. To compensate, the body blows off acid in the form of CO2. This is why your patients start having Kussmaul breathing or Kussmaul respirations. Deep, rapid breathing is a way to lower CO2 and raise pH. It's our body's attempt to compensate for what's happening. How do we measure ventilation? Well, a few ways. Respiratory rate. How fast or how slow are they breathing? If we breathe faster, we blow off more CO2. If we breathe slower, we retain more CO2. Tidal volume. How deep are they breathing? And of course, end-tidal CO2. This tells us effectively how much CO2 is being eliminated. When ventilation fails, we fix it by assisting or supporting breathing. Some examples could be a BVM or an ambu bag for rescue breathing, CPAP or BiPAP for non-invasive positive pressure support. Of course, in more severe cases with both oxygenation and ventilation, there's always intubation and mechanical ventilation may be needed. Just remember, if your patient isn't ventilating, CO2 builds up quickly, your pH shifts. This makes ventilation a high priority in both exams and real life. Once airway and breathing are stable, the next priority is circulation, making sure oxygen-rich blood reaches the tissues. Circulation is all about perfusion, our ability to deliver blood and oxygen to vital organs. If circulation fails, it doesn't matter how well the patient's breathing, the tissues still won't get what they need. We assess circulation by checking some of the following. Blood pressure tells us about perfusion pressure. Heart rate, capillary refill is a quick bedside indicator of tissue perfusion. And of course, skin. How does it look? Cool, clammy, and diaphoretic are never the words we want to see or hear. If circulation is impaired, here's how we intervene. Of course, first, if there's any external hemorrhaging, we're going to stop the bleed. Next, we replace volume in the way of IV fluids or blood products. And then, of course, last but not least, vasopressors. We use vasopressors when fluids aren't enough to maintain perfusion. But always remember, you have to fill the pump with fluids before we can start squeezing on the vessels. So fluids before vasopressors. To prioritize on the NCLEX and in real practice, follow the ABCs systematically. Airways always first. Is it open and patent? Breathing. Remember, breathing is broken down into oxygenation and ventilation. And of course, last but not least, circulation. Is oxygenated blood being delivered to the organs, and are we able to maintain perfusion? This structured approach keeps you from getting distracted by less urgent problems and ensure you always pick the safest and most life-saving interventions first. Thanks for watching. I hope this breakdown of the ABCs helps you feel more confident with NCLEX priority questions. If you found this helpful, hit the like and subscribe button and turn on notifications so you don't miss the next video. Check out breakingdownnursing.com. I'll leave the link below. See you at the next lesson.